afternoon, staff. Thanks for taking the time out of your busy day to listen to our refresher presentation on drugs for urinary incontinence. I'm Amira. I'm a third-year pharmacy student at the University of Newcastle. I'm also joined by my fellow students Natalie and Rachel. Before discussing the drugs, we will go over some myths and facts of incontinence. Starting off, we hear a lot that medication is the best treatment for urinary incontinence. In fact, medication is not actually effective enough to treat conditions such as overactive bladder and urine leakage. Medication will only be effective when combined with behavioral changes, such as decreasing intake of fluid, following a schedule for urination, pelvic floor exercise, and weight loss. We may also hear that only women suffer from urine incontinence. However, while it's common in women, it also happens in men, especially those who previously been treated for prostate cancer. Other myth that we hear is incontinence is normal and it's an inevitable part of aging. While actually incontinence is more common as we age, but not all older people will develop incontinence.
Before discussing treatment options, I'd like to remind you of the 3 types of incontinence, as it will help guide drug choice. Stress happens when the bladder is full, pelvic floor is weak, and intra-abdominal pressure is put on the bladder, causing urine leakage. It is not related to psychological stress. Overflow is due to pathological changes to motor or sensory neurons, or blockage of the urethra, causing buildup of urine and leakage. There are several pathologies behind overflow incontinence, including blockage of the urethra. This can be caused by bladder stones, urinary tumors, enlarged prostate, or a narrow urethra, damage to bladder sensory or motor neurons, and these can be caused by things like diabetes or multiple sclerosis. Urge, which is also called overactive bladder, is the most common type of incontinence. It is a strong, urgent feeling to urinate, even when the bladder isn't full or even half full. This is usually followed by leakage before reaching a toilet.
Urge incontinence, need to void that cannot be deferred, inability to hold. This is commonly caused by an overactive bladder, a condition in which muscles in the wall of the bladder contract in an uncontrollable manner. The reason why this happens is unclear, but it's likely to involve problems in the nervous system.
So when formulating a treatment plan, first consider the type of incontinence, underlying pathology such as urethral obstruction, other medical conditions like kidney disease or medications that might interact or be contraindicated, lifestyle factors such as water, caffeine or alcohol intake, medications that could trigger incontinence, we'll go through that a bit more at the end, and non-pharmacological treatment options like pelvic floor exercises and avoiding triggers. The first group of drugs we'll discuss is the anticholinergics, such as oxybutynin and tolterodine, which are popular choices for incontinence. So these medications work by inhibiting acetylcholine's effect on smooth muscle in the bladder, which stops contractions and causes relaxation. They also increase bladder capacity and delay the initial urge to void. Unfortunately, they have the characteristic side effects of anticholinergics, such as blurred vision, urinary retention, dry mouth, and constipation. Let's go over oxybutynin in a bit more detail. It comes in tablet or patch form. The tablet is 5 milligrams given twice to 3 times daily, up to a maximum of 20 milligrams. For geriatric patients, initiate at a lower dose of 2.5 milligrams twice daily and titrate up slowly according to response. For children, 5 milligrams twice daily up to a maximum of 15 milligrams. The patch is dosed at 3.9 milligrams per day and is applied to intact skin on the abdomen, hip, or buttocks. This is removed and reapplied to a different area every 3 to 4 days. Patches are not recommended for children. The safety and efficacy has not been established at this stage. Application site reactions are common and may be intolerable to the patient. Check other medical conditions before commencing treatment, as oxybutynin has several contraindications such as glaucoma and obstruction of the GI tract. And as always, check for allergies or hypersensitivities.
The next medication we'll discuss is mirabegron, also known as Betmeger. Mirabegron has similar actions to oxybutynin, but without the anticholinergic side effects. It's in the class of beta-3 adrenoreceptor agonists. It works by relaxing bladder muscles during urine storage, increasing bladder capacity and decreasing frequency of non-voiding contractions. Side effects include increased blood pressure, inflammation to the nasal pharynx, and urinary tract infections. Starting dose is usually 25 milligrams once daily, which can then be increased to 50 milligrams once daily based on efficacy and tolerability. Tablets must be swallowed whole with a glass of water and can be taken with or without food. It may take up to 8 weeks to see the full effects of the 25 milligram dose. Because the side effect of mirabegron is an increase in blood pressure, it's contraindicated in individuals with severe or uncontrolled hypertension. It should be used with caution in patients with other degrees of hypertension. So what can we do if oral or patch medication are ineffective or unsuitable for a patient? If this is the case, botulinum toxin, also known as Botox, is another option we can recommend for a patient. Botox can be used for incontinence due to damaged nerves, like in MS or spinal injury, or for incontinence due to an overactive bladder. It is injected into the bladder wall by a trained urologist, but so you're aware, the dosing is 5 units of Botox injected in 20 sites of the detrusor muscle, 100 units maximum. The onset is within 2 to 3 days and lasts for about 12 weeks. However, it's not to be used in men with bladder outlet obstruction. The mechanism of action of Botox is to block peripheral acetylcholine release in the bladder. Acetylcholine is the neurotransmitter responsible for contraction of the detrusor muscle. It also appears to have action on sensory neurons by reducing or preventing pain signals. The adverse effects of Botox generally include injection site reactions, such as pain, swelling, and weakness of the area. In addition, with bladder Botox injection, there is a high incidence of urinary tract infections and painful urination.
So we have some special cases for you guys to consider. Children who wet the bed, incontinence in postmenopausal women, men with urinary retention, patients who request a herbal supplement. We'll do a quick MCQ to help refresh your memories. So what's the best treatment option for children who are over 6 years old who wet the bed? So the answer is A, desmopressin, which is an antidiuretic. It comes in oral tablets, wafers, and a nasal spray. Check the dose equivalents before switching formulations. Fluid restrictions while taking desmopressin is required before bed. What would you use for incontinence in postmenopausal women? So the answer is B, estrogen cream, which also comes as a pessary. It's also known as Ovestin, and it's the most suitable treatment for this group. Topical treatment is preferred as systemic estrogen therapy may worsen incontinence. What would be the best treatment option for men with urinary retention due to outflow obstruction? So the answer is C, alfuzacin, which is a selective alpha blocker. Unfortunately, it needs to be used alongside a catheter. This treatment is not suitable for women as it can worsen incontinence. What's the preferred herbal supplement? The answer is A, pumpkin seed, which is a popular natural treatment for overactive bladder. A recent study suggests that pumpkin seed oil may be able to treat or prevent symptoms of overactive bladder and other urinary disorders. Researchers are looking into pumpkin seed oil more, There may be more studies on pumpkin seed oil and overactive bladder in the future. And finally, what medications can cause incontinence? So the answers are antihistamines, muscle relaxants and sedatives, diuretics, narcotics, and alpha adrenergic antagonists. Just as a quick reminder of the medications we just mentioned, incontinence can be related to its mechanism of actions, like in diuretics, or a side effect, like in diazepines, narcotics, antihistamines, and alpha adrenergic antagonists. Check your patient's medication history before suggesting a therapy for incontinence. It may be as simple as ceasing or switching one of their regular medications. And here are just some references for you to check out if you'd like some more information. Thanks for listening to our presentation, and feel free to shout out questions or type them in the chat box.